Welcome to our next voyage on T-10, the show that explores the future of learning and technology in healthcare. I'm your host, Tim Fitzpatrick. On today's episode, you'll hear from Jason Rose, CEO of AdhereHealth. Today, we're talking about a $500 billion problem. You might be familiar with Jason, who has been at the helm of AdhereHealth since 2018, but has over 3 decades of experience in value-based care. Prior to this, Jason served in executive roles at Inovalon, steering the company through its successful IPO back in 2015. He's also a Forbes Business Council member and a frequent contributor to the American Journal of Managed Care. Under Jason's leadership, AdhereHealth has been pioneering the use of AI, data, and telepharmacy to optimize medication use. It's the only national telepharmacy solution operating at scale in the United States and touches over 30 million consumers across the country. Jason has guided AdhereHealth's transformation these past 5 years. I really enjoyed learning more about the company's PRM, the first of its kind patient relationship management software. It's fascinating to hear how Jason and his team think about data and how they triangulate that siloed information into a set of specific, actionable recommendations in real time. To learn more about it, AdhereHealth, connect with Jason, or read some of his writing in Forbes and AJMC. All links are available in our show notes. We're ready to go. Please enjoy the voyage with Jason Rose. It is a pleasure and great to have you on T-10. There's a question that has come up in listening to your background and knowing that you've been at this in healthcare technology for multiple decades now, and having gotten your start at GW and kind of paving the way for a lot who would come after you. I want to know, what is your take on, first of all, where healthcare technology is today, and then we want to hear your story, how you got here. What is your origin story, so to speak?
Great, Tim. And first of all, thank you so much for inviting me to the podcast today. I'm really looking forward to this conversation. Where my take on healthcare. So if you think back, and it's funny, I hear 30 years of being in this space. It makes me feel like a dinosaur, but I'm not that old actually. But if you go back into the mid 90s, there was no healthcare tech space back in the 90s, and so you fast forward to today, there absolutely is a healthcare tech space. It's thriving. I think everyone recognizes that technology absolutely needs to drive outcomes for healthcare and drive improvement in quality of patients' lives. And it's a clear indication of where technology has transformed other industries. It's just that healthcare is so far behind. So as much as I believe that we have the right tech to make some positive changes today, I think that healthcare is just many, many, many decades behind nearly every other industry of where it ought to be. And so I think there's ripe for opportunity, and there's a huge space for us today.
Amazing. And I know you're tackling one of the probably the hardest, but also the most expensive challenges we have in the healthcare system. I'd love to hear how you came to be working on the problem you are now. And you talk about 30 years, and I tried to be generous with saying a couple decades.
Yeah.
Take 30. How has that changed? Right, your experience. You decided. Have you been working on medication non-adherence the whole time? What led you to wanting to work on this problem in particular, and leading AdhereHealth? I'd love to hear that side of the story as well.
So for the last couple decades, I've been in the value-based care space. And so my entire career, or nearly my entire career, I've been focusing on how to leverage technology to drive healthcare outcomes. And so in the last 20 years, there has this value-based care concept has become an important aspect of not just what the government is driving towards, but really I think all commercial organizations are driving towards. So back before I was here, I was at a company called Inovalon, which I was very pleased to be a part of, a startup that went multi-billion-dollar IPO, and really an anchor in the healthcare industry. And Inovalon's a fantastic company in measuring outcomes and processing data and all of that. What attracted me to Adhere was going a step further, which is focusing on the biggest problem that you were just relating to, Tim, is now that we have evolved many of the basic aspects of processes and measuring of processes, things like HEDIS and other PQA measures, just what are the processes? Are they working? And, it's now value-based care has really started to really drive focusing on those hardest to reach, most vulnerable Americans with social determinants of health. And so what drew me to the company I work for now, AdhereHealth, is that we focus on that group. And adherence is not just medications, really. It's all adherence to all clinical protocols. And so, but what is the most important aspect of patient care that is problematic, or one of the most important issues, is the fact that patients don't take their medications. And it's not just a matter of people just not choosing not to. It's just that oftentimes they can't or they don't know that they need to. And so it's a 20% of the entire U.S. healthcare spend is this problem. It's unnecessary medical costs. It's $500 billion every single year that is caused by that. And it really gets down to not that we don't have good technology, not that we don't have fantastic clinicians, and we have good government public-private partnerships in place, but what are we doing to achieve the quintuple aim of healthcare? So you think about the triple aim of healthcare, Don Berwick, 2008, which is better patient experience, better healthcare outcomes, lower cost of care. The fourth aim is better clinician experience, which I'm going to get to in a second. And the fifth one is improved health equity. And so to me, those last two that have been added to the original triple aim, really important. Clinicians want to do the right thing. They often don't have the tools to do it. They don't often have the data, a comprehensive data set to know right now in this moment, what do I need to do? Because they don't have a wide breadth of what's going on with that patient because they don't have the data. And then secondly, health equity. There are large cohorts of patients, not just in the United States, but across the world, who are perpetually those who are driving the highest cost of care because they're underprivileged and most vulnerable. And tackling that problem is a key to actually achieving better outcomes. It's the key to getting patients their medications. It's the key to improving testing rates and compliance on HEDIS measurements and all that. It's those most vulnerable Americans. And we're at the point now where the tech is in place, the regulatory framework is in place, and then there's a mind share that we need to focus on health equity.
So Jason, I appreciate you. You mentioned quite a few things that I want to kind of pull on here for a second. First of all, HEDIS and PQA. For people that may not be familiar, I will say just some context here. This audience is increasingly interested in value-based care. So both your experience and your background, but also what you're working on now is highly relevant. And I think, especially in kidney care and nephrology, where we're starting to see meaningful traction in this world, but we're learning from what you've been working on for a couple of decades. You wrote something recently about the force multiplier in Medicare and thinking about it and the opportunities of improving some of those quality ratings. Can you give us an idea why those matter? First of all, define those things for people who may not be aware of HEDIS and what quality measures look like, but then what is the relationship between what it is you're working on, value-based care, and some of these quality measures?
Yeah, so let's take this at a really high level, and then I'll narrow it down to specifically how it applies to Medicare Advantage star ratings, which is the value-based framework that the government put in place 13 years ago. So at a very high level, there is a focus on how you can improve outcomes and reduce costs of care. That's really, in a nutshell, value-based care. And so how do you achieve that is a different story. So Medicare Advantage, which is about 30 million members today, It's over 50% of all the Medicare beneficiaries are in a private health plan, which is a Medicare Advantage plan. And CMS, as a part of the Affordable Care Act in 2009, they flipped the switch to say, we're going to reduce how much money you make, Mr. or Mrs. Health Plan, in terms of reimbursement, but you can make it back. It's about 5% of the reimbursement. You can make it back if you prove that you're doing the best outcomes in the country against all your competition. And so that is, in a nutshell, star ratings. So it's Darwinism in healthcare. It's survival of the fittest. There's 5 stars. 4 stars get you in the money effectively. And if you get 3, 2, or 1, you get no money. So if you aren't at 4 or 5, you're not in the top echelon. You cannot compete with the rest of the plans for new membership or retain your membership. You don't have the money to invest in your product to provide the best benefits, and you're frankly at risk of your job if you are working there. And so it is a critical aspect of how the government laid the framework out as a part of the ACA. So when you think about 50 measures make up, each of them are evaluated separately against all the plans in the United States. Doesn't matter about the region, doesn't matter about the size of the plan. It's just an equal footing. If you think about the 50 measures, there are about 50% of the weighting. They're not all measured. The measures are not weighted equally when they ultimately score this every year. Medication adherence is a force multiplier of, if you don't do well on the measures that are related to showing that patients are taking their drugs 80% of the time or more every year, then it's nearly impossible to actually get to that 4-star marker, which gets you about $400 per member per year. And again, makes you relevant. And so that's the force multiplier. Because if you think about, zoom out of this government wonky stuff, think about medications. If I don't take my medications, my blood sugar glucose is going to be out of range, which is a different measure within star ratings and what's called HEDIS and quality measurement. If I don't take my diabetic medications, I'm at risk for chronic kidney disease. If I don't take my diabetic medications, I'm at risk for for having glaucoma and things of that nature with eye exams. If I don't take my statin, I'm at risk for all these other different measures and so on and so forth. So if you believe, I always like to say, if you believe in medicine, then you believe that medicine can actually improve outcomes. And so what do we need to do to overcome the barrier of care? Food, water, shelter, access, health literacy, so that they can get their medications, so that they can live happier, healthier lives. And then the health plan, if you're the health plan, I actually can achieve my financial goals as well because I've actually improved care.
Amazing. So again, thank you for kind of teeing that up. You mentioned the why now of there's regulatory in place and now we have tech that's increasingly in place. So let's now switch gears and talk about, with this foundation you've painted for us, what does the tech look like and where does Adhere fit into that world?
Yeah, so Adhere really, I've thought about this a lot. If you think about that quintuple aim of healthcare, improving clinician experience, with all due respect to the original reasoning around the improving clinician experience, I think the original intention was about reducing clinician burnout, which was particularly important with the pandemic, and it's still important today. I take a different perspective on improving clinician experience. So where Adhere does is that we intake data, massive amounts of data, tens of millions of members, and we're importing this on a daily basis. This is medical claims, pharmacy claims, eligibility data, hospital admission, discharge data, on and on and on, SDOH data. And we intake that and we process every single day to identify risk at the measure level of the individual issue that's being scored and the patient level, holistically speaking. And so where the clinician experience comes into play is that we arm the clinicians. These are doctors, pharmacists, pharmacy technicians, and nurses. And this is, for us, we're really more of a telepharmacy. We're probably the only national telepharmacy that is at scale, and we use these software clinical workflow purpose-built tools that we arm the clinicians with, that has the data of yesterday to show what should be focused on right now with this member or this doctor who's on the phone with you to drive today, right at this moment. And then based on the information that the self-reported from the patient or doctor, real-time AI helps drive additional analytics of what do I do with that information right now or in a few days. So we really drive clinician experience so that we can really achieve ultimately lower cost of care, better patient experience, better outcomes, et cetera. And so we feel like we are really the only company that's actually doing that at scale. And we use what's called a patient relationship management PRM framework to do that.
So the patient relationship management framework is something I definitely want to dig into, because I've seen you talk about how EHRs are not the answer. And I know that oftentimes people talk about, well, EHR is a problem and it's a segmented, fragmented market. And obviously we know it's a long tail. Could you kind of compare and contrast the two just to help people understand what that PRM looks like and how it compares to what people are probably familiar with?
Yeah, so let's compare the data within health plans and the data within provider groups. Just to start with the answer to that question, Tim. So if you think about claims data is miles and miles wide in terms of information. If you think about an electronic health record for that specific doctor group or hospital that the patient happens to go to, it's going to be miles and miles deep of clinical information. And so, but they're not the same thing. There's a lot of differences. So really in the best world is that you have both. You have the clinical information and you have the claims information. Claims information is good for indication of issues or potential risk. The clinical information is a good indication of what's happening right now at a clinical level to reduce abrasion with the conversations with the patients and things of that nature. But if you think about just medications, so the beautiful thing about medications is that they're adjudicated every single day. Patient goes to Walgreens or CVS, they buy a drug, as long as it's not cash pay, they buy the drug, it transacts the next day. You actually know the patient picked up that drug at Walgreens, et cetera, et cetera. And you can calculate a medication adherence ratio, as often as you want. And so medical data, just the nature of the beast, because of billing processes in hospitals, is sometimes months delayed. And so a really good indication of actual health today is the pharmacy data. And so EHRs don't possess if an average Medicare patient sees 5 to 7 doctors a year. So that EHR for Dr. Smith's practice, he has no idea about Dr. Jones's practice, this health system that is, a couple miles away, the specialist that the patient's seeing. They have no idea. They only know what's in their EHR, and neither do the other EHR systems. So we have interoperability in concept, but those health systems and provider groups, they can't or won't share that data with other organizations. It's technically possible, but it's expensive, and there's a lot of regulatory problems that prevent it from happening, and frankly, business. Clinicians don't want to or businesses don't want to share their information with each other because they don't want to lose their patients. So lots of issues there. So if you think about the claims data, the payer has all the data. If I'm like Cigna or United, Aetna, whomever, I have all the claims data for every single doctor, every drug they're taking. I have all the diagnoses codes that have been coded, and I'm paying all the bills. And so I have this mile-wide information stream. And then what I don't have is I don't have the clinical information from the HR, and I don't have what the patient's in their head, right? And so combining all of that in a good experience with the patient is with first and foremost focusing on assuming that the patient wants to be well, that there's a good reason why they didn't take their diabetic medication. It's probably because of a social determinant of health. Tackling that first and foremost. Mrs. Jones, did you take your medication for your diabetes? No, I haven't. Well, tell me what's going on in your life. Well, I can't afford food on my table, so I can't pay for the drug and the food, or my car's broken down. I can't get to the pharmacy, or I don't have a doctor, or I'm in a pharmacy desert, or I'm in a food desert. Those are the actual issues that prevent Mrs. Jones from actually taking the drug. And so focusing on that, use the health plan benefits that are available, use the community and social services networks that are available, church pantries, all those things are available. Fix that. That's the issue. It's not the patient not taking the drug. The actual issue is food, water, shelter, and Maslow hierarchy of needs. That's what it really is. So that you can actually get the patient compliant on clinical guidelines and medications. And that's a PRM. And you do that holistically. You don't do that transactionally. We're not calling them once and then that's the last time you hear from us. It's maybe 5, 6, 7 phone calls in a matter of a year of identifying the social determinant of health, addressing it, making sure it was addressed, get the patient on the medication, make sure they're persistent on it, there's no issues and questions, and again, constant feedback loop, use the data and the monitoring systems to make sure that everything is staying the way you wanted it to be, and the patient is in a good place. And that's how you use a PRM. You think about CRM, Salesforce.com. PRM is the healthcare version of that.
That's great. I used to cover CRM once upon a time in a past life. And as you're talking, I'm thinking about all the different data sets that go into a PRM and what makes it tick. And I'm thinking, well, it's kind of like, relational database, I think Airtable, and basic spreadsheet, I think Google Sheets or Excel. And PRM just feels like the logical evolutionary next step for healthcare, especially given all these challenges. So this is a great segue as we're kind of thinking about the future. Wrapping up, I want to talk about top barriers and challenges. It sounds like interoperability and multiple data sources and lagging time scales on the data are a challenge, but the opportunity at the same time is addressing social determinants of health and actually being able to combine those data sources in a way that provides real-time insight for clinicians and gives some direction. So I want to make sure I hear from you on what those are. I think the best way to do that is to wrap up with our final frontier that kind of nicely packages, first and foremost, what you see as a top opportunity as you think about the road ahead for you, for Adhere, for the industry at large. What do you see as kind of that top aspirational, optimistic goal on the road ahead?
Yeah, so I unabashedly am going to focus on the big elephant in the room, which is medication adherence. No one's really doing a good job at it, frankly. I say $500 billion a year in medical costs. By the way, that's not my number. That's the Annals of Pharmacotherapy study in 2018 on 2016 data. So it's now 7 years. It's a lot of people have actually aged in the last 7 years, particularly the baby boomers. It's really probably closer to $1 trillion. So it's 20% of U.S. healthcare spend. That's the big opportunity. How do we focus on that? How do we actually get down to everything we've just spoken about? How do we actually get that issue resolved and really get into the weeds of vulnerable Americans? I think the pandemic, by the way, I wrote a lot of articles, did a lot of speaking on this too. Pandemic was a perfect, I think, frankly, wasted opportunity to tackle that in a really big way, because who were most hurt in the pandemic? It was not the genetic code. It was the zip code. It was the same patients that exist today, pre-pandemic and post-pandemic, who were not getting their drugs for their chronic conditions, who ended up having COVID. Lots of people got COVID. Those are the ones who actually got hospitalized and had higher mortality risks. And so that was a perfect example of why we need to focus on that massive problem that no one is doing a good job on today.
That's great. And Jason, just so you're aware, we will make sure that all of the links to, because I saw that you had published quite a bit, you had done quite a bit of speaking on this topic. So I'll make sure that is covered. It's linked in the show notes and people can find it. That kind of gets us into the challenge. What do you see as a barrier in your way of being able to address and go tackle some of these opportunities and adherence?
You only have certain data available, and that is effectively available daily. So what is available daily that's useful that might change day to day that you can actually make a big impact on. And so, like I was saying earlier, pharmacy data is adjudicated daily. Use the data. It's use the data in a meaningful way to drive analytics off of that. Bounce that up against the medical data. So here's a interesting fact: is that here is amongst so maybe the only organization, or amongst the only very few organizations in the world that actually can take medical data, claims data, and assess that with active pharmacy data and see where there is problems. So a patient has got epilepsy. There's an ICD-10 for epilepsy because Dr. Smith has validated the patient has epilepsy, and there's not any NDC code for pharmacy. The patient's not taking anti-seizure medication at all, ever. And so that patient in the next 6 to 18 months is going to be in the hospital, and they may not come out of the hospital. And it's going to cost about $30,000 to $50,000 when that happens, and it's going to be horrible for everybody. And so that's as an example. And that's not even a government measure. That's just a commercial, self-insured employer, ASO, health plan issue. Any employer is going to have the same problem. And there are thousands of examples of what I just described. And so just matching the data that's available and doing it quickly, and then augmenting that with, I think, where EHR is helpful, find the clinical data that you can augment the claims data, combine it together, and then use self-reported information of what's really going on. Why are you not taking this medication? Give the clinicians the tools to actually drive the needle. So I challenge everybody who's a stakeholder. I'm going to flip it around, Tim. Is that the challenge is that let's get the government and let's get the commercial industry, let's get the payer, public-private partnerships to drive this more so. We're going too slow. So the Inflation Reduction Act of 2022 was great in concept, and we're making strides on that. It's not enough, and it's not fast enough. Why are we waiting so long? Let's get going on these things. I challenge everybody to focus on 20% of U.S. healthcare. And so if we could knock out half of that, that would be hundreds of millions of dollars every year. It would solve so many problems, and also people would live better. And so, and for unknown reasons, Adhere is one of the only organizations purely focused on that as a mission.
Well, I'm excited about a call to action. We rarely see them on the show. So let this, this is a moment in history for the show, I think, for us in general. And I obviously hope to see it too. I think sometimes it takes decades for people to see the world the same way you do. So I'm excited for people to finally catch on, and hopefully the IRA is one thing that gets us closer to building that momentum that you need to Adhere and that others need to see to get this moving. So let's keep going on the tech trend. I want to know what are the things that you're following now. I know a lot of people are excited about AI, and you've mentioned it before, and kind of your ability to think about what's next and tomorrow's recommendations for clinicians and improving that experience. What are the tech trends that you're following in your seat right now?
Yeah, the thing, obviously, wherever we can do more interoperability is fantastic. I think one of the most important, and whenever we can use AI, and I think everyone's talked about that. I think all those things are fantastic advances. The most interesting thing, so a lot of these things have been in place for a long time, but they're just now becoming implemented. And so I think that, to me, it's the things that we've been talking about for a decade or longer that are actually being implemented now. And that, to me, I'm following that. Is that how are we taking interoperability, massive data processing at scale, and then things like AI and machine learning and NLP and all those different types of new tech. How are we using that to really drive the needle? Because it's great to have it, on in a magazine. It's a totally different story to actually apply it into a business at scale, not as a one-off kind of wonky little startup. I mean, actually building out scalable products that really drive it, and you're doing it at a cost that is reasonable. And so I use AWS. I think AWS is great. I also have Azure as well. It's really expensive. to process a lot of data. And so finding ways to do these things nimbly at a lower cost, because cost is a problem too to do these things, but focusing on the business case of how you apply these new technologies is really exciting to me, and I'm avidly focused on whatever we can do to be more efficient.
That's great. And then just as we're wrapping up here, last two on the final frontier, especially on the business side you just mentioned, and you're someone that has been now an executive at a large scaling up, growing organization. You've been in this healthcare technology field for 3 decades. What media are you consuming today to kind of help you think about these challenges, or to help you think in your current role as CEO of the organization? What books, media, podcasts are you consuming that you might recommend to the audience?
Yeah, so in my space, I consume. I'm certainly going to consume all the healthcare kind of table stakes to the modern healthcare's Fierce Healthcare, the AHIP Smart Brief. Um, there's actually a guy named, you can look this up, Rama on healthcare. He's a good guy. He has a good consolidation of information that I read, so I can see all things I'm not following, and that's actually great consolidation, and it's free. And those are, of course, the Wall Street Journal. But I also like to read, frankly, I like to think about history and biographies of whether the, I, Rockefeller, recently read that, George Lucas, Spielberg. I like to read books about innovators and leaders that actually did something different. They broke the mold. And Elon Musk's book is obviously it's an older book, and obviously the Jobs book is a phenomenal book. But I like to read things people who've been there, done that. They broke the mold. They went against the grain, and they kind of took on the forces at will of status quo. And so a book I recently read, I credit my wife for telling me to read this, is called Breaking the Habit of Being Yourself: How to Lose Your Mind and Create a New One. But Breaking the Habit of Being Yourself is kind of the major title. It's by Joe Dispenza. That's a great book. It's a deeply meditative book, and it forces you to think about the things that you do that make up who you are, and break those habits to be someone better. Everyone can be better. And so, and it's an excellent book. It's it's not new. Joe Dispenza, for those people who know who he is, he's a unbelievable leader for the human race, really. And I love that book, and that really made me think quite a bit. And it's been on my mind since I read it a couple months ago.
Amazing. That's a great recommendation. We'll include all of these. I will also come back to you and let you know which habits I've broken because I've read it.
Great.
So I appreciate you sharing. Last one here. You already mentioned quite a few people. Is there any healthcare or technology leader that you're following, aspiring to? I know you mentioned Elon, you mentioned Rockefeller, George Lucas. Anyone else come to mind either from the healthcare side? We have Rama on healthcare as well.
Yeah.
And then also the technology side.
It's funny. I was just talking to someone yesterday about someone who I really appreciate. His name is John Halamka. I had the opportunity to meet John 20 years ago. He probably doesn't remember me. Might remember the when I met him though. If you remember David Brailer, Dr. Brailer was the first healthcare IT czar for George Bush. And so I put on the first, remember the RIOs, which is the big regional health information HIEs for the United States back in 2004. So I, with the HIMSS chapter here in Tennessee, we put on the first panel of all the regional health information organizations, and had Dr. Brailer, who is number one most powerful person in healthcare that year, moderate a panel. And so and Halamka is an amazing person. So I like to follow what he does. I think he's currently CIO of Johns Hopkins, UF Beth Israel. But frankly, there's lots of different healthcare leaders. Certainly I look at every one of the health plan CEOs, whether it be Cordani or now Sarah London, or on and on and on. So I like to look at what they read. I'm kind of a geek about this. I like to read the quarterly earnings and listen to the actual recordings and read the annual reports, because it really, the payers. I mean, people may not like to hear this, but it's a fact. The payers have won in terms of healthcare. They are in charge. They hold all the purse strings. The ultimate payer, of course, is CMS. So I focus on those who are controlling the financials, so that because they're going to drive what's going to happen in the future, and so that's why I kind of focus on that. And then obviously anything that CMS puts out on government regulatory changes, I'm an avid reader of all that wonky, detailed stuff in the Federal Registry and final rules and things of that nature. That those of you who are in the CMS world understand exactly what I'm talking about.
I think we have quite a few actually CMMI policy wonks who are thinking about kidney care. So I know there's at least a small but very fervent bunch who will appreciate and probably share some of the articles
would be
with
another
you.
Great place to go, to Avalier. Which when I was at Inovalon, we had acquired Avalier. Dan Mendelsohn founded it. Dan Mendelsohn's now the president of JP Morgan Health. He's a friend of mine too. But yeah, they produce great stuff too, Avalier.
Excellent. We'll make sure it's all linked here. Jason, we really appreciate you coming on, sharing what you're working on at Adhere. It's been an absolute pleasure talking to you, meeting you, and we're, of course, rooting for you. We can't wait to see what you do with medication adherence and how you tackle these challenges in the road ahead.
Thank you so much, Tim. I really enjoyed the conversation.